Hello, everyone, and welcome to another episode of Retina Synthesis. Today, we have Dr. David Lally, who is Director of Research at New England Retina Consultants in Springfield, Massachusetts. David, welcome back to Retina Synthesis.
Thanks so much, Carmen, for having me back. I'm excited to talk about APX 3330 today.
So APX 3330 is an agent, a drug for the treatment of diabetic retinopathy taken orally. So what's the pathophysiology of this drug?
Sure. So yeah, this is a first-in-class oral medication, and it blocks Ref1. And Ref1 is a transcription factor regulator. So by inhibiting Ref1, you block the activation of both HIF1 alpha and NF-kappa B. And that leads to reduced levels of both VEGF and inflammation back to a normal physiological state. This drug was initially developed by Dr. Mark Kelly at the University of Indiana, and it's been very well studied previously in other conditions such as hepatitis and solid tumors. And the safety of this drug was found to be very good in those trials, with really only a mild rash as the potential side effect.
So how does it work in diabetic retinopathy?
Yeah, so the fact that it can reduce VEGF levels and inflammation, and that it had a really good safety profile in those initial studies in hepatitis and solid tumors, it really made diabetic retinopathy, it seemed like a good target for this therapy.
What was the trial that you recently reported on?
Yeah, the trial, so the trial is called the Zeta-1 trial, and this is the first time that this drug's been studied for an ocular disease. And the Zeta-1 trial was a phase 2 randomized double-masked placebo-controlled trial, and it looked at APX 3330 in subjects who had moderately severe to severe NPDR or mild PDR. So we're talking about DRSS scores of 47, 53, and 61. And those patients, they were randomized in the 1-to-1 fashion to receive either this oral APX 3330 at a 600 milligram dose daily, or a placebo pill that was taken orally daily for 24 weeks. And the primary outcome was the percent of subjects with a 2-step or greater improvement on the DRSS score at week 24. So this is the typical primary endpoint that is used for past therapies that have been FDA approved for diabetic retinopathy.
How many patients were enrolled?
Yeah, so a total of 103 subjects were randomized across 25 sites in the United States.
So the vision in these patients was good. It had to be better than 20/63. Is that correct?
Absolutely. Yeah. So yeah, you're absolutely right, because one of the enrollment criteria was that at baseline, the central retinal thickness could not be greater than 320 microns. So we specifically were not looking, this was not looking at diabetic macular edema eyes, and we wanted eyes with good visual acuity. And one of the reasons we did is that if patients have significant diabetic macular edema at baseline, and that edema worsens during the trial, then often we can't sit and let that diabetic macular edema be untreated for 6 months as the patient's getting blurrier. So we would have to treat those patients with anti-VEGF drugs. So, and that would confound the results of what this therapy could do for diabetic retinopathy.
So vision-threatening complications studied as well?
They were, absolutely. Yep. So there were many secondary and exploratory outcomes. So we looked at vision-threatening complications. We looked at both ocular and systemic side effects over time. We also looked for any signs that this therapy could be helping any other parts of the body. So one of the nice things about an oral therapy is that it potentially could have off-target treatment effects that could be beneficial to the patient. So we looked at things like the kidney function of the patient as well.
So what was the primary endpoint results?
Yeah, so the result in the Zeta-1 trial, the APX 3330 did not meet its primary endpoint in those percent of subjects who had two-step or greater improvement of the DRSS scores at week 24. And what we saw was that in both the APX 3330 and the placebo group, 8% of those subjects in both groups had a two-step or greater improvement. However, in phase 2 trials, we are often learning about the drug's potential efficacy for the very first time in vivo. And often we can see other efficacy signals that can redirect our development plans when we go into phase 3. And the Zeta-1 trial might be one of these instances because, interestingly, we did see an efficacy signal when we looked at the change in the binocular DRSS scores. And so binocular DRSS score is something we're not typically accustomed to looking at. And this is calculated by the sum of each eye's DRSS change together. So if one eye improved 2 steps and the other eye improved 1 step, then the binocular DRSS change would be an improvement of 3 steps. And so when we looked at this change in binocular DRSS score at week 24, we saw that 0 of the APX 3330 subjects developed a binocular 3-step or greater DRSS worsening. And that was in contrast to the placebo group, where 16% of those placebo subjects developed a 3-step or greater binocular DRSS change. And so what we learned was that APX 3330 may have more of an ability to stabilize diabetic retinopathy disease as opposed to improve it.
So what's the word on progression?
Yeah, so when we thought about this result, it made a lot of sense to us when we really think about APX's mechanism of action, where unlike an intravitreal injection that will drop the VEGF level to virtually 0 in the eye, APX 3330 is not squashing the VEGF level in the eye, but rather we think it's bringing it back to a normal physiological level within the eye. And that's because it's a transcription factor regulator. And so this drug may not be able to reverse like a moderate NPDR or a mild PDR, but it may be able to prevent worsening of the diabetic retinopathy over time. And, when we go back and look at that primary endpoint, which was not met in the trial, we used the typical FDA approvable endpoint for registration trials for diabetic retinopathy, which is that 2-step or more improvement. And, I think a lot of that decision was because that's the common known path to FDA approval. But the prevention of diabetic retinopathy progression is also a valid primary endpoint, according to some previous remarks by the FDA. And an oral pill is quite different from an intravitreal injection, right? As an oral therapy will treat both eyes simultaneously, while an intravitreal injection does not. And our patients experience the world through both eyes. And so, when studying systemic therapies, we should be thinking about looking at the treatment effects of both eyes when we're looking at what the value of that treatment is to our patient.
What about vision-threatening complications?
Yeah, we saw that they were similar between the groups. So the rates were incredibly low. So there was no difference in terms of that happening. And those rates were incredibly low. And again, the reason being is that it's a 24-week trial. The majority of the eyes had moderate NPDR. And like we mentioned earlier, they did not have any significant diabetic macular edema at baseline.
So what's the next step?
Yeah, so the next step is an end of phase 2 meeting is planned with the FDA later this year, where they will discuss the binocular DRSS change to see if it can be a valid primary endpoint for the registration trial. I'll also make a comment on the safety, because with any oral therapy, the safety is incredibly important, to be looking at. And we actually saw in the Zeta-1 trial that APX 3330 was very safe. In fact, we saw that there was higher rates of treatment-related adverse events in the placebo arm as compared to the APX33 arm. And really, when we look at the side effects of APX3330 that were attributable to the drug, there was a small risk of developing rash, and that was similar to what was seen in the previous non-ocular studies. And those rashes were mild, I should say, and they were self-limiting, and none of those patients needed to stop therapy. So it looks like we have a safe drug here, and it looks like we have something that might be able to prevent progression. And so really at this point, we're really waiting on the FDA and the end of phase 2 meeting to see if the FDA will permit the binocular DRSS change as a valid primary endpoint for their registration trial.
So this seems to be positioned for patients early in the diabetic retinopathy disease course.
Absolutely. Current standard of therapy for moderate NPDR, the majority of us, you can treat it with anti-VEGF injections to keep the retinopathy from progressing over time. And it is, those therapies are FDA approved for the treatment of diabetic retinopathy. But in clinical practice, the majority of us are not injecting eyes with moderate NPDR. And that's because of the treatment burden for the patient. And a lot of these patients are at the age where they're working, and to come to our office and have an injection in their eye every few months is not really a path that the majority of them want to follow. So, I think it's really a change in kind of thinking about diabetic retinopathy. I think we're so used to, with our anti-VEGFs, have been so excellent, and we're so accustomed over the last 10 years of studying these anti-VEGF injections in eyes, and we're seeing diabetic retinopathy scores improve. This is really a change of thinking of really, can we treat patients earlier? And we don't really need to make them get better if they have moderate NPDR, because they're seeing okay. It's really about just preventing them from going from progression to PDR, where they can have a vision-threatening complication later on.
Well, this is certainly an intriguing result. And let's help the FDA lets us go to the next step, because preventing disease is something that is quite important.
100% agree with you, Carmen. Yeah. Thanks so much for having me.
Thank you for joining us again.